A vital signs report from the CDC, just released on May 7th, shows that nearly a third of pregnancy-related deaths happen during the pregnancy. Slightly more than a third occur during the delivery or the week after, and the final one-third 1 week to 1 year after delivery. This is a problem that the AHA is working to address. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer at AHA and your podcast host. Maternal health is a high priority for AHA and its member hospitals and health systems. AHA has a long history of working with national organizations such as the American College of Obstetrics and Gynecologists, who in turn bring their own partners to the cause. This includes organizations such as the Alliance for Innovation on Maternal Health, the American Organization of Nursing Leadership, and the CDC, the Centers for Disease Control and Prevention. Improving maternal safety and outcomes in the U.S. is a top priority. While we have seen some success in improving outcomes, we must continue to pursue advancements in maternal care. We means hospitals, health systems, clinicians, and community partners, all supporting mothers and doing more to improve their care. In this Advancing Health podcast, Dr. J. Bhatt, Senior Vice President and Chief Medical Officer at AHA, speaks with Rear Admiral Wanda Barfield, the Director of the Division of Reproductive Health for the CDC.
We're in for a treat today. It is my honor to speak with Rear Admiral Wanda Barfield, Director, Division of Reproductive Health, National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control. Wanda, thanks for being here today.
Well, thank you so much, Jay. It's really an honor to speak with you today.
We're going to start with a little bit about yourself. So, Admiral, could you talk about your current role and what drew you to the work in reproductive health at the CDC?
Yes. So, Jay, I direct the Division of Reproductive Health in the National Center for Chronic Disease Prevention and Health Promotion at CDC. What drew me to the CDC and the division in particular was really my passion and love for the care of infants. However, as a clinician and a neonatologist practicing in the U.S. military, I realized that I was really interested in a mission that was broader. And I also understood in my experience as a clinician that the care of babies really depend on the care of mothers. And when I had an opportunity to learn more about the CDC, I understood that there was a real great opportunity to work with individuals who cared for not only babies, but also mothers, families, and communities. So it's really an honor to work at CDC, and particularly on this important public health issue of eliminating maternal mortality.
Is there a particular set of activities or any specific initiative that you're particularly have been proud of at the CDC in your time there?
There's quite a few activities. It's a wonderful place, and I have the honor to work with so many amazing scientists from many different disciplines. But I would say one of the exciting areas is one that's going on right now, and that's really the opportunity to focus on reducing the risk of death for mothers and reducing maternal mortality. We're doing a lot recently with regard to a funding opportunity announcement that actually closes in May that allows states to apply for maternal mortality review committees.
Excellent. Well, that I know is welcomed by the field and states that are so active in this work and want to make a difference. So thank you for your leadership and the CDC's significant presence in this space for supporting the field. It's my understanding that this issue is quite personal for you, speaking of maternal mortality. Could you share a patient story to bring this critical issue to life and illustrate the importance of your work there?
Jay, as you may know, the death of a mom is always heart-wrenching, particularly for those who care for mothers and babies in the hospital. It's something that you always remember, and it resonates throughout the hospital and resonates throughout the community. In addition to my opportunity of having the honor to see the joy of birth and delivery of a healthy mom and a healthy baby. Unfortunately, I've also experienced the tragic moments when a mother does not survive that circumstance. But recently, this issue became very personal, even here at CDC, as we lost one of our own. And it was truly a devastating experience. Shalon Irving was a lieutenant commander in the U.S. Public Health Service Commissioned Corps, and she was a wonderful CDC epidemiologist. She earned a dual doctorate in sociology and gerontology, and poignantly, she worked to address social determinants of health. I was fortunate enough to help mentor her and watch her grow as she came to CDC as an EIS officer and then continued to develop. She was a wonderful colleague and friend. 3 weeks after giving birth to her daughter in 2017, Shalon suffered complications from high blood pressure and died. She was just 36 years old. I think of Shalon often as we work to strengthen our efforts around maternal mortality prevention. The work of the Maternal Mortality Review Committees is a way that we can tell a systematic story so that we're especially motivated at CDC to strengthen the Maternal Mortality Review Committee effort. It's an important opportunity for us to tell the important stories surrounding a mother's death and try to prevent future deaths.
Thank you for sharing that, Wanda. Dr. Irving's story is a poignant reminder of how fragile this issue can be. And so I think it is important, as you've illustrated, to have review committees in place to then implement the learnings from events that we find to be preventable and have the capabilities to support mothers and the care teams in having a healthy birth and post-pregnancy care delivery pathway. So one of the patients I took care of young in my training career was a woman that was affected by this issue as it related to hemorrhage as a complication. And that led to a system-wide conversation about particular protocols and approaches to caring for that mother, led to team drills and simulations. I think that it certainly is possible to get to zero in this case.
So, Jay, you bring up some really important points. I mean, a maternal death should be a zero event. And there are some big picture system level changes that we need to consider to make sure that all women receive high quality care during pregnancy and at delivery, as well as up to a year afterward.
Yeah, completely agree. And I think what's been interesting for me in this work over the last 6 months is I've really seen some bright spots and some promising examples all around the country, how organizations are working to position mothers for healthy births and the appropriate care postpartum. What have you seen in the field that has worked? And certainly from your vantage point at CDC, what are some practices that you've seen work?
I think some practices that are really important include things like standardizing the response to obstetric emergencies and making it easier for women to receive the prenatal and postpartum care that they need. We can also work with colleagues in the American College of Obstetrician and Gynecologists, as well as the Health Resources Services Administration, also known as HRSA, to promote AIM safety bundles. And these bundles are a standardized approach that helps to improve the care to women. We can also support perinatal quality collaboratives, also known as PQCs, and the Maternal Mortality Review Committees in all of their exciting and innovative work that allows us to work together to identify the problems and to work to address them and ultimately improve the quality of care for mothers and babies. Just to talk a little bit about some of the work that we're learning at CDC, we know that the most recent data from CDC's pregnancy mortality surveillance system that we just released through the vital signs report shows that pregnancy-related deaths happen before, during, and up to a year after delivery. And about a third of the deaths occur in each of those time periods, as you mentioned in the introduction. And most importantly, 3 in 5 pregnancy-related deaths could be prevented, no matter when they occur. And so this is important for us to understand in terms of the opportunities for prevention.
I agree that there are key opportunities for prevention, and I think that it takes the care team and the partners in the community to make it happen. And when you think about the impact CDC is having on this issue, what are some of the developmental challenges that you're seeing, the economic and social implications? You did speak about the data earlier, but as we think about the broader community perspective, what is the issue if we don't turn the tide on this?
I think that it's really important that we understand issues that occur locally, and particularly issues around the social determinants of health. It's important that we understand that women need to receive care not only before and during pregnancy, but also after pregnancy. Pregnancy is a window to lifelong health. And so if we're able to look at strategies that promote women's health and mom's health and well-being throughout their pregnancy, as well as in the postpartum period, we're really going to end up with healthier outcomes for healthier moms and babies. And there are some strategies that we can think about, particularly during pregnancy. For example, home visits, or postpartum, thinking about healthy start programs.
Great. And some of what you're alluding to also may have been brought out in some of the research that's happening at CDC. What are the health policy and clinical care implications of your research? Or what are the top line sort of messages from the research that you and others may be doing on this issue?
Some of the big pictures, sort of system level changes that we can consider is that all women receive high quality care during pregnancy, at delivery, and up to a year afterward. We need to standardize our response to obstetric emergencies, as you alluded to earlier, and make it easier for women to receive the prenatal and postpartum care they need. We can work with the American College of Obstetricians and Gynecologists, as well as our colleagues in HRSA, to promote AIM safety bundles. We can support the perinatal quality collaboratives and the maternal mortality review committees and all of their exciting, innovative, effective work that allows us to work together to identify problems and work to address them and ultimately improve the quality of care for mothers and babies. But we also need to think about what we can do in communities to make sure that women receive the care that they need, not only during pregnancy and at delivery, but after delivery. There's a window of opportunity in terms of follow-up that we need to address. We need to look at resources in the community to include home visits or healthy start programs. We need to think about how we can provide other supports to ensure that women get postpartum follow-up for any issues identified during pregnancy, as well as checking on their health after delivery. Things like mental health screening, as well as subsequent linkages to care, are very important.
Excellent. Those are wonderful insights about what the field can do on this issue, so thank you. And one of the things that we haven't talked about yet that I think also is an interesting issue is the C-section rate. Early in 2012, the American Hospital Association, with a number of partners, including ACOG and the CDC and others, worked on the issue of early elective delivery. And that concerted effort made a big difference over the subsequent years in reducing early elective delivery. And we know that C-sections, primary C-section rates have been higher, and that can increase the rate of complications for mothers. And so what are you seeing on that issue related to C-sections, and what can we do there?
Yes, Jay, as you alluded to, C-section rates are fairly high, and we're seeing increasing rates among women who are considered low risk. Part of the quality improvement efforts that have been focused on reducing elective deliveries still need to be revisited. It's still an important issue, and we need to consider how we can reduce the rates of cesarean section. Part of the issue is understanding also the increasing complexity for pregnant women in terms of increasing medical issues and chronic disease. And taking those issues in consideration is also another factor that's important in understanding why C-section rates may be increasing.
Now, you already alluded to some of the actions hospitals and health systems can take to eliminate maternal mortality and reduce morbidity. Are there any other particular ones that you think are important that you haven't mentioned yet?
Some of the issues that are important in terms of reducing maternal mortality and morbidity is thinking about the health of women even prior to delivery, ensuring that we're improving preconception health, that we're improving health of women even before they become pregnant.
Yeah, I think this notion of how do we go upstream to ensure the health of mothers and expectant mothers is really important. The prenatal care pathways and access to prenatal care is critically important, and we're seeing a number of ways that the field is engaging a broader interprofessional team and community health workers and the voice of mothers to help shape better care and access to care in the prenatal period. That's why I think the coverage gains that have been made through the Affordable Care Act, it's important to continue the work to preserve that access mothers may need during the prenatal period. Now, internationally, we see that countries are doing better on this issue. Are there particular bright spots from around the world in terms of actions that are being taken in terms of the care of mothers that the field can learn from?
I think that we have an opportunity to learn from other countries about improvements in health and the reduction of maternal mortality in other developed countries. Some of these issues relate to systems of care and how we can identify risk-appropriate care for women, meaning that when a woman is high risk, making sure that she's receiving the right care at the right time in the right place. There are also opportunities for us to continue to follow women. Again, the findings from the MMWR show that the postpartum period from a week up to a year after the delivery of an infant is still a risk for mortality. So we can learn in terms of thinking about ways that we can more fully follow women during the postpartum period as concerns arise.
Wanda, one of the really important issues I see we've got to address on making progress on maternal mortality and morbidity is the issue of disparities. Now, African American mothers are 3 times as likely to die giving birth, and that is an issue that has complex factors driving it. And so we've got to look at the data, we've got to understand access to care, but there's also this issue of bias and mental health that play into maternal outcomes. So could you talk a bit about your view on what we can do to address disparities and cultural sensitivity as well as implicit unconscious bias?
Jay, you raise an important point on the issues of racial disparities in maternal mortality. African American women are 3 to 4 times more likely to die due to pregnancy, and this issue is just unacceptable. What we need to think about are issues in terms of systems, systematically making sure that all women are receiving high quality care during pregnancy, delivery, and through the postpartum period. But we also have to think about the circumstances by which women live and social determinants of health that may drive health inequities and may increase their risk of death. We also need to learn from maternal mortality review committees in order to not only better understand the clinical factors that might contribute to a woman's death, but we also need to think about community factors, provider factors, even family and parent factors that might provide more information around the circumstances leading to a woman's death. This is why it's so important to work with maternal mortality review committees. It's a real opportunity to uncover and understand the circumstances around a woman's death in order to prevent future deaths.
Thank you, Wanda. I think that we need to continue to learn from practices across the field on this issue. And one of the things that I've also seen, and I'm curious if you've seen this, is that sometimes when you look at the data just across 1 year, you don't necessarily see the disparities. But when you march it out over a longer period of time, then the disparities may emerge. So I think that sometimes it's even the time period by where you look at the data and how you stratify it by both place, race, ethnicity, and other variables appropriate to the organization and the community.
Yes.
Wanda, we know mental health, behavioral health, both access and treatment are critically important as postpartum depression or certainly in the prenatal period. Could you talk about what work is happening in this area and what you see as promising practices and what are other things we might need to think about?
Yes, Jay. Mental health is really an important issue. And in terms of mental health, it's very important to recognize and acknowledge that it's a factor in maternal health and maternal mortality. A recent report from 9 maternal mortality review committees that was released in February 2018 showed that mental health conditions are an important leading contributor to maternal death. So we need to ensure that providers use evidence-based approaches to screen and treat women for mental health and substance use disorder. We need to work collaboratively to provide more access to perinatal psychiatric consultations and resources to effectively prevent, identify, and manage pregnant and postpartum patients' mental health and substance use concerns.
Mental health is an important priority as it relates to the health of mothers, and we need to continue to share practices that work. So when we think about what actions we can take over the next 3 years to make significant progress on this issue, we know that California has made over the last 7 to 8 years progress on cutting the rate of maternal mortality. What are you hoping to see over the next 3 years by hospitals and health systems, community-based organizations, and public health to make progress on this issue?
Well, I've been very encouraged to see public health join with health systems to improve care and strengthen the capacity through perinatal quality collaboratives. I'd like to see that continue to grow and strengthen. I also see that over the next years, the opportunity to really address risk-appropriate care so that healthy moms deliver in locations that have strong capability to care for them, and high-risk moms also are receiving the care that they need, and that care is really adapting to that particular risk. We also have an opportunity in the future to use tools such as Locate to help identify health facility capabilities so that they're prepared to receive women at an appropriate risk level and give them the best care possible.
Excellent. I think all wonderful suggestions. And we stand ready to work with public health and create even stronger clinical community linkages so that we eliminate preventable complications and mortality. And so when we think about what CDC's plans are for work in this area, what are some of the future actions? I know you spoke about the maternal mortality review committees and supporting states in that regard, and that's fantastic, and continued work to convene and bring folks together. Also think about virtual care as that is increasing across the country and to meet the needs of rural communities. I think that's an important area as well. So could you talk a little bit about your plans and how we might think about rural communities?
I think that we need to keep working together to obtain better data points to identify the gaps and drivers of maternal deaths and disparities, and also identify quality care initiatives that will have the most impact. And when you talk about rural communities, it's important for us to continue to understand the data in those rural communities, as well as think about strategies that will help best address the challenges of living in a community where it may not be as easy to access risk-appropriate care. We need to also continue to support state perinatal quality collaboratives to work with improving the care of moms and babies. Maternal mortality review committees and PQCs can work hand in hand to identify areas for intervention and then implement rapid quality improvement efforts to address those issues. And we must remember that high quality care needs to extend into the postpartum period up to a year after delivery, when many of these pregnancy-related deaths occur. I think that there's some wonderful opportunities for AHA to continue to be a wonderful partner in this effort.
Great. Well, we look forward to continuing to partner and support you in the initiatives moving forward. And one of the areas that's also, I think, interesting is opioids. I mean, I think, right, that there's this intersection between opioid exposure that moms face and the issue of complications and then neonatal abstinence syndrome. And so are there particular work streams engaged in that effort? And are there things the field should consider and think about in terms of addressing opioid addiction and maternal morbidity?
There are numerous efforts going on at the federal, national, and local level to try to address the opioid epidemic. And I think, as you've alluded to, this is an issue really where we need to think a lot about prevention as well. So one of the issues that we're looking at CDC collaboratively within our agency is how we can prevent opioid-related deaths of all individuals, all ages, and how can we look at populations that are particularly vulnerable, including pregnant women and infants. With regard to maternal mortality, we do know that there may be increases in pregnancy-associated deaths due to opioid overdose. And the maternal mortality review committees provide a good example of where we can look at the data to better understand the contributing factors related to pregnancy-associated deaths due to opioids. But we also have a good opportunity to understand the factors related to opioid use disorder using a survey called the Pregnancy Risk Assessment Monitoring System, or PRAMS. This survey is being utilized by PRAMS states to better understand the risk of opioid use disorder among women who've recently delivered a live-born infant, as well as to follow up those infants in terms of their longer-term outcomes at 9 months of age. We're also looking at quality improvement efforts around opioid use. There are many PQCs that are trying to focus on the reduction of neonatal length of stay through standardized protocols to treat infants with neonatal abstinence syndrome, as well as identify pregnant women with opioid use disorder and making sure that they receive medication-assisted treatment and standardized use of buprenorphine.
Excellent. Thanks for sharing those insights. I think we continue to double down on our efforts related to the issue of opioids and maternal addiction and neonatal abstinence syndrome. And I know a number of folks are working on this area, including the federal government, CDC, some of our state hospital associations, and certainly those hospitals and health systems that are thinking about this issue. So we'll want to share those practices. Now, CDC and you are providing extraordinary leadership on this issue. And so how can anyone listening to this podcast learn more about the work you've done in this area and are planning to do?
One, staying connected with AHA. We're very excited that we're all sharing information about our collective work. But for more information, your members can simply go to www.cdc.gov/reproductive health to learn more about the activities in our division. And there's also general information on maternal mortality, as well as the work of our pregnancy mortality surveillance system.
Thanks so much, Wanda. We are so grateful for your leadership and partnership, and certainly more to come. And we look forward to continued work together on this issue so that we can all make a difference and help deliver care and prevention that our mothers and babies are all deserving of.
Well, thank you, Jay, for bringing this issue up. And thank you for all the work that you and AHA are doing to really try to help all health providers to understand the emerging issues in maternal health.
We want to thank our speaker, Admiral Barfield, and then all of you for listening to this podcast. This is one resource in a package of resources to support the field on the issue of improving health for mothers and babies. Last year, we launched the Better Health for Mothers and Babies initiative to share best practices and proven tools and showcase the successful efforts of our members and partners, like the CDC and the Alliance for Innovation on Maternal Health. This initiative that's promoting better health for mothers and babies, taking action and saving lives, calls on hospitals and health systems to evaluate and act on your data, examine disparities, engage the voice of mothers and families, and partner with clinicians and other stakeholders in your community. There are proven interventions that make a difference in each of these areas. And for example, in California, hospitals and health systems have put many of these interventions in place and reduced maternal mortality in half. We know many of you are engaged in similar efforts. Let's share what's working, and let's all be champions to improve health for mothers and babies. Watch for additional resources from AHA on this topic, and please visit our website at aha.org for further information on this important initiative. This and future podcasts on this topic will be available there, as well as on AHA's podcast channel, Advancing Health. Thanks so much, everyone. See you next time.